Hello, everyone. I'm Bernie Eliakis, President and CEO of CorneaGen. Thank you for participating in this evening's webinar, which is entitled From Referral to Recovery, CTAK and the OD-MD Relationship. We're pleased to offer this webinar featuring three wonderful ocular specialists who work together out of Ohio. Dr. Suzanne Kirk and her colleague, Dr. Katie Greiner, has referred patients to her, and Dr. Bill Wiley. Today's webinar, you're going to learn how CTAK fits into modern keratoconus treatment plans, when and how to refer patients for CTAK, how to gain insight into post-CTAK recovery and ongoing patient management, and how incorporating both surgical and non-surgical approaches to keratoconus treatment can improve outcomes. Our guests will take you through the questions throughout the show. You can submit a question anytime during the webinar by using the questions box in the upper right-hand corner of your screen. Click on the questions icon, and it will open up a text box for you to write and submit your comments or questions. We'll also take the time at the end of the webinar to answer any further questions posed during tonight's session. We'll do our best to answer as many of them in our allotted time. I want to point out that we have a library of webinars which cover the science behind CTAK's innovative approach for treating keratoconus, pre and post-surgical pearls, and there are many cases to witness. These can be found on our website under the Education tab. Please check them out at your earliest convenience, as they are hugely informative. Now I'd like to introduce our presenters. Dr. Kirk completed her undergraduate studies at the University of Illinois in Champaign-Urbana and went on to receive her medical degree from Loyola University School of Medicine, graduating with research honors. She then completed her ophthalmology residency at Loyola Medical Center in Chicago, where she served as chief resident. Dr. Kirk was actively involved in global outreach, participating in surgical mission trips focused on cataract and pterygium procedures in underserved communities, and maintained a strong commitment to clinical research, presenting her work at multiple regional and national conferences. Welcome, Dr. Kirk. Dr. Greiner is recognized as an optometric leader in Northeast Ohio and beyond. Dr. Greiner, optometrist and vice president of physician engagement for Midwest Vision Partners, dedicates her practice to comprehensive eye care for the whole family, including a special interest in corneal diseases and irregularities, with a strong focus on hard-to-fit contact lenses, including scleral lenses. In 2025, she was awarded the National Keratoconus Foundation's Keratoconus Doctor of the Year Award. Welcome, Dr. Greiner. And finally, join us is Dr. William Wiley, who's board-certified ophthalmologist who has pioneered many eye procedures in Northeast Ohio area. Dr. Wiley is medical director of the Cleveland Eye Clinic. Dr. Wiley participates in many clinical research studies, and because of this, is often able to offer his patients technology that is not widely yet available in most clinics in the United States. To date, Dr. Wiley has performed more than 50,000 cataract and refractive surgeries. Welcome, Dr. Wiley. Excellent. There you all are. Okay. So I'm going to go behind the scenes here in a bit and let you all carry on with the presentation. I'll join again at a break to answer any questions that have been submitted by the audience and some of the pre-submitted questions. So with that, please take it away, all.
Great. Well, thanks for having us. It's really exciting to be involved with CorneaGen and CTAK. And, I feel like I've been at this for, over 20 years. And it was always for keratoconus. We never really had great treatments, even, let's say cross-linking, which was revolutionary when it first came out. We would just sort of, say, okay, well, we can lock your cornea in place and prevent progression. And the patients were always like, well, what about my vision? When's my vision going to get better? And we'd always kind of be stuck and sort of struggling with really not great answers. I remember for the past, I think we've been doing cross-linking for over 10 years. So 10 years ago, we were like, well, just hang in there. We're going to lock it in now. And one day there'll be a technology that may help improve your vision. But the current goal is just to lock it in. And what's great is now with CTAK, we really now have this opportunity to improve vision, and it's been great to be involved with it. My co-presenters here, Katie Greiner, we work a lot together with just sharing the cases. She's been kind of doing the same thing. She's been treating patients that sort of like hang in there. Maybe we can do a scleral lens or a complicated fit or whatever, but eventually that, you run out of steam and you need to have that patient have, uncorrected vision that's functional or improved. And thankfully, it's been great to work with her on this. And Suzanne Kirk, also, it's been great. She's been collating the data probably, I think, over the past, year and a half. I think we've collected over 100 eyes or over 50 eyes that were recently presented at ASCRS. And it's really cool to see how much improvement we've seen with CTAK. And it's really great to be involved and have this opportunity. So feel free if you either one of you want to chime in or just a couple of remarks to get us going.
Yeah, thanks, Dr. Wiley. It is really fun in an OD-MD relationship, having these patients, like he said, that, cannot wear scleral lenses for the 18 hours a day that their eyes demand, and now being able to offer them a way to be functional again in glasses. Most of the patients, once they end up in my chair, just really cannot function without the contact lenses. And this has given them a way to be able to take a break now from those lenses and wear glasses again. So we have a great relationship sharing patients. We're excited to go over that relationship tonight and also share some cases that we've all, three of us, has done together.
Great. I know, Dr. Kirk, you've never really functionally practiced, out in a world where we haven't had CTAK. I think since day one, we've been doing CTAK. So you sort of jump right in and, you've already done, I think, probably a half dozen to a dozen cases. And so you've, since you've been in practice, we've had this great technology. So you're really at the forefront. So thanks for, helping pioneer this with all of us. So, what is CTAK? It's a customized segment of allograft, specific, it's custom made for the patient. So we've had other implantable technology for the cornea, in particular Intacs, but those are sort of almost one size fits all. I know we had different sizes, but it really wasn't customized to the patient. And we always had that, but really it was, the patients had kind of borderline results. Some patients did well, but many just did borderline. And you really didn't have this viral effect or, a practice growing effect. The patients, it was the best alternative, but nothing great. But thankfully, with this treatment with CTAK, it's customized to the eye. So you take a customized map, send it off to a reading center, and then a treatment is, generated for that eye. So as far as thickness, length, size, placement, all those things are really customized for the cornea. And more or less the goal is to reshape that cornea, to take say an irregular astigmatism eye, to kind of reshape it and get better quality of vision and decrease the regular astigmatism and increase best corrected visual acuity by flattening or centralizing that cone. We can go to the next slide.
So detection is key, and for all of you attending tonight, I'm sure that you are very aware of this, but in a few slides here, we're just going to go over the early to advanced stages of diagnosing keratoconus. 3 typical things I would look for. It starts with an abnormal posterior float. We really like to use the Bell and Ambrosia display on the Pennicam to help detect it early in a form-frust manner. Then we're looking at the abnormal corneal thickness, where there's an obvious distribution of change, thinner at the area of the cone, and then looking for that clinical evidence on your slit lamp exam for this non-inflammatory thinning of the cornea, usually inferior in nature. And of course, your own clinical suspicions. We understand that keratoconus happens, more in our teenage to 20s and kind of, will lock itself in naturally into the 40s and 50s. Looking for a family history, which we're seeing more and more relation to family history, eye rubbing, especially in what Dr. Wiley, you always said your dad said to rub with their elbows, right? Rub your eyes with your elbows.
Yeah, so, yeah. You should say you can rub as much as you want with your elbows. And yeah. I'd always, because I'd always like, Dad, I got to rub my eyes. He's like, oh, yeah, rub away. Just rub as much as you want with your elbows. And as a little kid, I'd try, and it's like impossible.
Yeah,
so.
That one has always stuck with me. I love that. I say that to my patients now too, but I give you guys credit for it. Those patients that just grind on their eyes like that and have a history of pretty excessive advanced allergy. And I think it is important to note, the first time you see inferior steepening on a topographer or a tomographer, that doesn't always indicate keratoconus. Sometimes we have to dig. I think poorly fitting contact lenses, especially rigid lenses, can really warp the cornea if the patient's not aligned properly, if their eye is dry. So I really pay close attention to that posterior elevation when I'm looking at keratoconus, or I even, if I'm really concerned, have them phase out of contacts for a short period of time to repeat scans. So I do think that's a good thing to note tonight. Next slide. So in the early stages of keratoconus, the thinning and steepening are obviously at a very minimum amount, and the corneal topography will show early changes again on the posterior float. And in these patients, we can often have them in glasses, and I'm excited for them that, you know, glasses are still functional, but I worry what's coming next, which then becomes that moderate stage where the cornea becomes, you know, steeper, more irregular, it thins more. Now their astigmatism is becoming more irregular. We're seeing these unique, you know, oblique axes, and we aren't getting great best corrected vision anymore in glasses. And we're reaching for, I typically go straight to a scleral lens, but we're reaching for more advanced contact lens methods. And then by the time we get to severe stage, which hopefully in our world of keratoconus now and technology, we don't have to ever have patients get to this stage. You know, we're seeing advanced scarring, the cornea, the Munson sign is pretty prominent. And these patients are then heading towards a corneal transplant. And I think I could speak for many cornea surgeons out there that their number one surgery they're not trying to perform, right, is a cornea transplant. There are so many other things we can do for patients before having to put them through a full thickness transplant or a DULC. So I'm excited again to talk about the options we have so patients are not progressing to this level. Next slide. Dr. Kirk, do you want to comment on this one? We were talking through it earlier. We thought this was an interesting slide.
Sure, yeah. So in terms of the degree of keratoconus, we're looking at the mild, moderate, and severe cases. And in these patients in the younger ages, we can do corneal cross-linking in mild, and then possibly doing ICL. If they're over 40 and they have keratoconus that doesn't appear to be progressive, you can do ICL as well. And then in moderate, we can, of course, do cross-linking in ICL, as well as offer them CTAK at that point.
And then I'm curious, you know, Dr. Kirk, your perspective. I know when you joined our practice, you were probably thinking, you know, we're mostly doing cataract and refractive, and now we have this, you know, cornea type procedure, and you weren't necessarily going down the cornea fellowship path. And you know, I myself, I'm not cornea trained, and you might be thinking, okay, well, why is, you know, the cataract refractive surgeon offering, you know, this, you know, cornea procedure? But what's interesting is, you know, it is a great tool for the cataract refractive or general ophthalmologist, because quite frankly, we're on that early line, and a lot of patients are coming in for, you know, refractive surgery. That's where we're catching it, or they're referred in thinking, okay, I want to get LASIK or do, you know, corneal refractive surgery. You need to find out that they have, you know, keratoconus, and, you know, or maybe a candidate for CTAK. And you have all the tools, you know, as a cataract refractive surgeon. You have the femtosecond laser. You can use, you know, VisuMax, or even if you have a LensX that can create the tunnel. So you have the tools, you have the skill set, you have the diagnostics. So it's a great, you know, fit. And I'm curious what your thoughts are, you know, when you head back to Chicago. Do you see yourself, you know, carrying this forward? You know, is this something that you're going to be offering to your patients?
Yeah, so it's funny. Initially, when I heard about it, I was like, well, you know, cornea transplant, that's not really what I was looking for. But I will say it is one of the easiest procedures that we perform. It's very quick. I would say pretty much after you do one, you can do 100. And initially I was, you know, oh, I don't know if I'll bring that back. That seems like a lot, but it's so easy. I just got off with our practice manager and gave them the CPT codes and everything. So we will definitely be bringing CTAK back to Chicago. It's been an awesome procedure, and our patients are so happy with their results as well.
Nice. So patient selection, you know, I think in general, we're looking for patients that are struggling with their best corrected visual acuity. Typically, if it's slipped worse than 20/40, and a lot of times patients were doing well, but and typically, maybe they're doing okay with their scleral lenses, but they need a break. And when they go to their spectacles, if they're not getting best corrected visual acuity 20/40 or better, often those are the best candidates. And this, by offering CTAK, it gives you that opportunity to get them, improve their best corrected visual acuity. And then often on top of that, not only is it best corrected, but a lot of times patients get an improvement in their uncorrected visual acuity as well. So more or less, it's patients that have that loss of best corrected visual acuity that's impacting their daily activities. Very similar to how you might evaluate a cataract patient, that's having interruption for their daily activities. You want to have, that sort of tail end of mild to moderate, and even into a little bit to severe. As long as I look at it, as long as they're not having that central corneal scarring, a lot of patients can benefit. And it's, you want to be careful. You want to set proper expectations, but if you can dodge or prevent a corneal transplant, a full PK, I think it's everybody wins. And a lot of our patients, we have avoided that by offering CTAK. But sometimes if there is that central corneal scarring, they've lost their, even if you reshape the cornea, they might not have improvement in vision. So those are the patients we kind of punt to full PK. But Kmax, 50 to 75. A lot of times though, Kmax, we're seeing patients with the high 40s that are often coming in that may benefit. It just all depends on how much irregular astigmatism is. And a lot of it's relative to their eye, what their normal was before keratoconus, and how is it sort of advanced. You do want to make sure though it's not like a form fruus type of keratoconus. If the thinning is peripheral, then those patients, right now we don't have a nomogram that really is applicable to those patients. So you want, the patients that have more the central, the paracentral thinning, but if it's peripheral, like a pellucid style, those aren't necessarily great candidates. So again, keratoconus comes in all forms, and I'll be honest, Dr. Kirk, you've analyzed the data, you've looked at a lot of the pentacams. In your mind, we see all types, the central cone, the paracentral cone, irregular oblique astigmatism. Really, as long as that Kmax and thin corneas are inside that 6 millimeter zone, I think they do well. But do you see, after analyzing the data, do you get a sense on who seems to have the best improvement? Is it, in your experience or looking at the data, and you've looked at multi-center data, what do you think, sort of sticks out as the best candidates or the more borderline ones?
Yeah, I would say the ones that have really high astigmatism tend to do the best. So usually it'll be ones where we can make that corneal shape a little bit more regular, that we've seen the most improvement in that manifest spherical equivalent after surgery, after the CTAK is done.
Yeah. So again, Kmax and the thinnest cornea, inside that 6 or 8 millimeter zone, and these are the classic crab claw shape that maybe are ones to avoid, particularly if it's pellucid pattern. Now, just because you see a crab claw, don't automatically rule them out, because you really, the only way to really know is if you do a pentacam and you see where that thin area is. Sometimes you can have a cornea that looks like this, and you have a thin area that's within the central 8 millimeter zone. So it may be pellucid looking true keratoconus, and those may do fine. But if you have the thin area that's outside that steep zone or outside that 8 millimeter, then those are the ones that you want to avoid. That if it's true, pellucid marginal degeneration, those you avoid. So if you're just looking at anterior Ks, a lot of times you can't tell exactly where that thin area is. So make sure you get a tomography and analyze where is that thin spot. So decision-making matrix. Do we have a slide for this, or do you want us to talk over? Okay. So a lot of times when a patient comes in, you're thinking, which procedure are you going to offer, CTAK or cross-linking? And there's great treatments. A lot of times it depends on where they are in the spectrum of keratoconus. And so in general, if they've lost best corrected visual acuity less than 20/40, CTAK is going to be in the matrix. And a lot of times I'll present to the patient, we have two procedures. One procedure, cross-linking, locks the cornea in its place and prevents progression. The other procedure is CTAK that can help reshape the cornea and help improve the vision, but it doesn't stop progression. So you have cross-linking that stops progression but doesn't really help the vision, and CTAK that helps the vision but doesn't stop the progression. So you have to kind of look at both and what's going on and what do they need. So if they've already had cross-linking maybe 10 years ago, you've already stopped the progression, and now you can do CTAK to help improve the vision. Or, if they're coming in, a lot of times I'll present both options. They're like, well, doc, why do I want to lock my cornea in at this blurry vision? Let's improve the vision first and then lock it in. And I know medically, we're not really sure. There'll have to be some studies that will help guide us if you should be doing CTAK first or cross-linking first. Right now, the studies aren't out, but at least the story makes sense to patients where they say, let's reshape the cornea first and then lock it in once the vision is in that better state. So if it's a virgin eye and the vision's worse than 20/40, we're offering CTAK first. And then once the vision stabilizes 3 months later, then cross-linking. If the vision is already pretty good, a lot of times they have one eye that's kind of poor, the other eye you're catching early enough, maybe it's 20/20, but you can tell it's going to drift, or there's already signs of keratoconus. Maybe you do cross-linking in that eye, CTAK in the eye that's irregular, reshape it, and then do cross-linking after. So each patient, you analyze differently, and you can offer it, one of the two procedures. And then some patients, in theory, you can do both at the same time. Typically, those are more of our cash paying patients. Right now, insurance is not likely to pay both if they're done at the same time. But if it's a cash paying patient, they want to save a trip, you can do CTAK with cross-linking. It's kind of nice. You have this tunnel and you can sort of introduce the riboflavin into the tunnel, onto the CTAK segment itself. And then you get this fast absorption, very deep absorption, and then you can cross-link after the CTAK is in place. So you can do, more or less cross-linking before, after or during, but a lot of it depends on where they are in that spectrum and what the patient's goals are at the time when you're first seeing them.
And I couldn't agree with this slide more. Dr. Wiley and I spent a lot of time talking about, when the appropriate referrals are. And, I think he very much agrees. We have to meet them where they're at. And there are patients that, cross-linking's been around for a long time. So a lot of the first cases we've shared were cross-linked first because we did it right away, in 2017. And so they still have done really well with CTAK. So don't delay a CTAK referral just because they've been cross-linked. I think the moral of the story is, this is the perfect situation for a virgin eye, but if they've had something done, still do it.
That's right. That's right. Dr. Kirk, do you want to walk through the procedure here?
Yeah. So here you can see, we'll start the video there. You can see that green light. This is our VisuMax, and we're creating that channel. It goes down to a circle that we make that's right in the center there. That's at the center of the cone. That's where we want that to be. So it's centered around where the cone is. And then we dissect that channel open, and we do this initially a little bit in the laser suite, but then you can also take them to the OR and prop that channel open again. And then you use that same dissector that is used for Intacs, and just make sure that that channel is patent, that you'll be able to fit the tissue in that channel. I will just say in the next part of this video, it's going to flip to the other way, but it does go 360 all the way around. But you can see that that tissue is going to go in the opposite way, but it's the same idea, that we're just making sure that passageway is patent, and we're just kind of feeding that tissue through. It is kind of like a wet noodle, the way that the actual structure of it is, but it is pretty easy to get it in. And then you can just kind of smooth it into place after you get the tissue in the right spot, and smooth everything out. And that's it. There's really not much more to it. A lot easier than it sounds. It's not a cornea transplant. I promise 16 sutures are not happening here. But it's a pretty slick procedure.
No, that's great. And you were lucky not to have done, you can play the video again, because we can talk about it as it's playing. In this eye, it happened to be a central cone. So the treatment was centered right on the cone, which happened to be the visual axis. But sometimes there's a plan that dictates it's going to be off center. It really depends on where that steep area is, what the nomogram is telling. So this one happened to be centered right on the visual axis, but sometimes it's paracentral, and it's all based on that preoperative Pentacam. Dr. Kirk, we used to do Intacs, and I swear I was the only one in my practice that was willing to do them. All my partners were kind of saying, I don't know, they tried it once and it's hard. Intacs, you'd think it'd be easier, but it's stiffer. You'd think, and it's smaller, you think it'd be easier to insert, but for some reason, Intacs is really challenging to put in. And CTAK, like you said, is really straightforward. And I think initially I thought it was going to be harder because it's not a plastic or PMMA segment like Intacs is. I was like, okay, how are we going to get this, this noodle into the cornea? But like you said, since it's been irradiated, it's stiff enough and it's got enough memory that it's relatively straightforward to in place. And I would say 10 times easier than Intacs. And now I just kind of kept it secret. Our partners, nobody else really knows how easy it is. I'm still the one doing it, and the practice I keep offering, but nobody really wants to take it up. I think they're scarred from the Intacs experience. So if you've tried Intacs and been burned, don't, and then you see this, you're like, oh my gosh, this may even be harder than Intacs. It's way easier, and straightforward.
And I will say too, in our data that we've been looking at, a lot of the issues with Intacs and, had their own issues, but that erosion through the cornea was a big issue. And we have not seen any of that with CTAK. So that's been pretty cool. The side effects have actually been really minimal. And so it's been an awesome procedure to kind of piggyback off of skills learned from implanting Intacs and then just take them to the next level.
Yeah, let's back up to the video one more time. I'll talk up over it. Yeah, great point as far as the skill. Like in general, very straightforward. We don't see that erosion like we did with Intacs. I'd say the one watch out, if there's any watch out, and it's not a contraindication, it's just have to be aware of situation, is if they've had previous LASIK, when you're doing that tunnel, you have to make sure the tunnel is below the LASIK flap, because otherwise there's a chance, and even when you're doing this dissection here, you can fool yourself. If you're not to the base of the CTAK channel, there's a chance you can be falsely into the LASIK flap. And if that's the case, the segment can extrude out of the LASIK flap. And that would typically happen during surgery, during implantation, because the LASIK flap has no resistance. So if you accidentally put it into the LASIK plane and not the CTAK tunnel plane, that's when you can get in trouble. So we recommend, if they've had previous LASIK, to make sure you can do, let's say, a corneal OCT, look and see how deep that LASIK flap was, particularly if it was a blade LASIK flap. Those are much deeper. They're probably 200 microns often in the periphery, even though the central LASIK flap was maybe 120 or 140 microns in the periphery. It often got thick enough where that plane is at 200 microns. So you'd have to make sure you're putting your CTAK plane below that. So you're probably, in general, the femtosecond laser with a virgin eye, we're at about 200 microns. If it's a previous LASIK, we're looking at 250 or maybe deeper, depending what a preoperative OCT is. So it's like the one watch out is the previous LASIK patient. Now that it's contraindication, because a lot of those patients maybe benefit the most. However, you just have to be careful surgically for those.
Dr. Wiley, if that does happen during the procedure, are you still able to then find the actual bed and get down there, or do you usually hold off at that point?
Well, it depends. If you just introduce it falsely, and there is a true tunnel underneath, you can find it and then reimplant it. So that would be fine. Not often, I've seen it happen a couple of times where the tunnel itself wasn't deep enough, and the tunnel, was made into the LASIK plane. So the LASIK plane was maybe 200 microns. The tunnel itself is around 200 microns. And now all of a sudden they're both at the same depth. So there's really at that point only one plane. And once you put the segment in, the LASIK flap is not stiff enough. The LASIK flap will lift in the periphery, and the CTAK just during insertion will slip out. So that's the one situation. So assuming you do have a true tunnel that's below the LASIK tunnel, you could proceed. And a lot of times what we do is when we first put the instrument in, you sort of dissect with your instrument. And if the instrument itself is dissecting more central than what the tunnel is, you're in the wrong plane. So you can feel for it, see it. If you feel the edge of the tunnel, then you know you're deep enough and you're in the true CTAK tunnel. In that place, you can then put the CTAK in. But if your dissector goes beyond the boundary of what the tunnel should be, then you know that tool's in the wrong plane and you've got to dig deeper or find the true plane.
Gotcha.
So it's been fun to be involved in the co-management of it. And, it was a lot of learning of, separate research when I first heard this come out. John Gellis is a friend of mine, and, I learned a lot from him as an optometrist. And then Dr. Wiley, spoke on this procedure at various meetings with our optometrists, as did Dr. Kirk. We actually host a keratoconus awareness day once a year, and Dr. Kirk came and spotlighted CTAK. And we had 2 of my longtime patients immediately afterwards sign up and say, we're going to go meet Dr. Kirk and Dr. Wiley to have this done. And they're 2 of the cases we're going to talk about tonight. So, I think, if you're new to CTAK, it's great to follow your cases and, collect some data, but then start getting your co-managing doctors, aware, because this isn't going away. Compared to the old Intacs, I can definitely say the aberrations are much less with this. The scarring is like, virtually nothing. I just had a old Intacs patient in today, and I just looked at those corneas and said, gosh, I wish, we would have had CTAK for her, because she is in a tough spot. And the patients I've seen with this are in such a better spot. So after they take care of the patient and see them for, 1 or 2 post-ops, then I'm able to get the patient back in my chair. And sometimes, this isn't always getting them out of contact lenses completely. Sometimes that's the goal. But for the cases we'll share tonight, they both went back into scleral lenses, but then they could also wear glasses. So I monitor refraction. I monitor with pennicams. If you are a co-managing optometrist that doesn't have a pennicam, you can send to a center that does and continue to co-manage that way. Most of these patients at this point have been cross-linked, but if they haven't, then we're watching that and sending back, like Dr. Wiley said, maybe 3 months after CTAK to lock everything in with cross-linking. And while HOAs still do exist for these patients, I do, again, think they're less than other prior procedures. And now we have HOA scleral contact lenses. And so I've been working in that realm, which really is just like the whole kit and caboodle for patients now. So we can kind of fix it all these days in our modern technology. Next slide. Okay, so this is a good place for us, I think, Dr. Wiley and Dr. Kirk, before we go into some cases, to take some questions if Bernie wants to come back on and give us some questions from the audience.
Yes, will do. Thank you, Dr. Greiner. Great presentation so far, great discussion. Let's pause and take a few questions, either that were submitted or were submitted ahead of time. And for those of you watching, again, you can submit questions in the box in the upper right hand part of your screen, and then you hit on the little arrowhead where it says submit a question, and you can type into the text box. So please ask questions throughout the presentation, and we can answer those at the end. But a few questions here, and some of these may have been covered in your presentation, but you can feel free to repeat from the content of the slides. But first one, for a keratoconus patient who is achieving good acuity in scleral lenses, but is highly lens dependent or struggling with comfort or wearing time, where do you draw the line between continuing specialty contact lens management versus CTAK? Would like to take that one.
Yeah, Dr. Grant, I have my thoughts on this, but I'm usually seeing them after they've made that decision. What's your take, and when do you make that referral, or when do you go to, offer that as an option and send them our way?
Yeah, I mean, scleral lens technology can get some of the most irregular corneas to really great vision, but if they have scarring, that's when, their best corrected acuity in sclerals declines. And that's also when we're saying, if they have central scarring, they're not going to be a great CTAK patient. So it's really, even my patients that are generally happy in their contact lenses, I like to make sure they know we're cutting edge on technology. We want them to know what options they have. And again, you know, you've heard me say these patients that just say, I can never get a break from my contacts. And, you know, I'm seeing this is a young population, right? They're starting careers, they're starting families. And for them to have to wear a contact lens for 12 to 18 hours and never get a break from that is really tough. And so, Dr. Wiley, that's when I start saying, okay, you know, most keratoconic patients have these crazy prescriptions. Dr. Kirk referenced these high astigmatism patients. That's when I send and say, we can really reduce that number, get you into glasses to give you a break, and still be able to wear contact lenses for maybe less hours during the day.
That's a great point, because I think a lot of it does come down to patient expectations and setting those properly. And I think patients should understand they're still going to get their best vision with contacts afterwards, and that's okay. Our goal is not to give them best vision without contacts. That'd be great if that occurs, and you do get some surprises. But really, the goal is to increase their uncorrected or spectacle corrected vision. So a lot of your patients that are doing amazing 20/20 with sclerals, maybe only 20/50 or 20/60 with glasses, and really struggle with glasses, feel like they're not comfortable or can't get by if they had to rely on glasses alone. So our goal is to kind of increase that spectacle corrected vision with CTAK, and it's expected and normal to have scleral lenses or whatever type of contact lenses they're wearing before they're going to go back to them. Obviously, it's likely a different prescription for them, but often it would be, my hope would be it'd be an easier fit. And I don't know, Dr. Greiner, do you see that? I know these are not easy fits. I've not, Dr. Kirk and I are sitting on the surgical side and we're not doing the tough fits. I'm sure that's a challenge. Does it make your job easier? And let's say if you had to compare this versus, let's say, Intacs, when you're doing an Intac scleral fit, do you find the difference or nuance? Is this an easier fit than they were before, or is it a little more challenging, but you've helped them with their spectacles?
I definitely think the fits have been easier. The first case we're going to share, we actually had him in a very complex design. We were changing, quadrant edges on lenses and really redesigning and trying multiple brands. And then after his CTAK, we were able to put him into a basic scleral lens again that's much easier to fit, less chair time for everybody involved, less remakes under the warranty. And so I definitely have seen that happen. Definitely also compared to the old Intacs, I would say it's a much easier fit. Those are the old Intac patients, their corneas just change and they're just, for a medical term, wonky. And those are difficult fits. So I have found these rewarding and less chair time for sure.
Nice.
So speaking of other, interventions that can be done, here's a question related to red flags. What are the red flags where you advise against CTAK and instead favor scleral lenses or cross-linking only Intacs, CAIRS, DALK, or PK? Any red flag areas for CTAK?
I think if their spectacle corrected vision is good, I think I don't want to necessarily fix what's not broken. And so if they're happy with their spectacles, I think those we go to cross-linking to say, okay, great, let's just lock it in now. You're happy with their spectacles. If they have that central corneal scarring, and no matter what we do to the shape, there's still a central scar, I think those are the patients that probably go to DALK or penetrating keratoplasty. I don't know, Dr. Kirk, if you have any other thoughts. And after looking at the data, and some multi-center, do you have anybody that you say, gosh, these patients just maybe don't do as well, or caution too?
Yeah, definitely that scarring is going to be the major limiting factor. What we look for first thing when you're looking at the slit lamp for them is there a scar there, and can we actually correct this vision, with an additional procedure to reshape the cornea, or is it something that's inherently blocking the vision, in which case the reshaping is just not going to do it for them.
Yeah.
Good. Well, speaking of, it was mentioned there in that question, CAIRS, and I know there's probably been a little bit of confusion out there. And so really just ask you all, what is the difference in your mind between CTAK and, CAIRS, corneal allogenic interstromal ring segments that you also hear about?
Yeah, I would think the way I would look at it is you have sort of let's say 3 categories of, intracorneal, segments, and you can have Intacs, which are sort of the most standard. They're not, you can change the shape or size a little bit, but it's pretty much one channel, one placement, and that's what you get. And then you have CTAK on the far other spectrum, where you're sending in a pentacam, and you have a full reading center. And I think I should know this, but the different permutations of sizes, shapes, thicknesses, depths, placement. It's almost infinite on how many different ways you could place that segment. So that's probably the most customized. I think the CAIRS is going to fit somewhere in between. It's a step forward as far as at least it's allogenic tissue as compared to Intacs. However, it's not nearly as customized to the patient. Number one. And number two, I've not done CAIRS, but I can imagine the insertion might be a little more challenging than CTAK, where that insertion, it's not irradiated, so it's not as stiff naturally. I think the cornea is going to be more flexible, a little harder to insert, not as customized, and not custom for that patient. It's probably a little more custom in Intacs, but not nearly to the degree as CTAK. I don't know, Dr. Kirk, Dr. Greiner, if you have any other thoughts, if you've seen or shared patients in that realm with the CAIRS.
Not only with you, Dr. Wiley, and the CTAK glory.
Very good. And it's over 3,700 configurations we have so far for
3,700,
and working on more.
Yeah. And that doesn't even take into account like the mapping as far as where the placement is, because you get this a relatively complex map of where you place that segment and how far off that central visual axis is that segment going to be. And each eye is a different place. So, that's amazing.
Great. Another question: what specific tomography patterns make you think CTAK is likely to perform well? Dr.
Kirk, do you want to hit this one?
I think we kind of touched on this a little bit on the ones that are go for it versus avoid. And so those are 2 really good slides. I'd say if we could maybe bring those back up, you can take a picture of them. But I would say we kind of talked about having that, inferiorly placed cone. Those ones usually do pretty well if we can make that astigmatism a little bit more regular. And any time where you have enough space where you can get that tissue segment in a spot that is, below that cone, to bring that cone back more central, usually we have, I would say, the best outcomes with those.
Very good. Very good. I think we'll keep it at that for the questions. Want to make sure we get to the case studies, and then we can ask some more questions at the end. So please continue.
Sure. I'll kind of intro the cases, and then Dr. Wiley, these have some of the, reading center work that comes back, so you can talk through that. But this is one of the first patients we shared, and LH, a 43-year-old male. He actually is in the tech industry, and so he had read about CAIRS and CTAK and actually asked the question of, what would be the next step. He was a LASIK patient in 2007. He actually, none of his surgery was with Dr. Wiley. It was actually out of state. Then he had an enhancement for PRK with PRK in 2015, developed the ectasia the year following in the right eye, and had cross-linking the year after that in 2017, again, still outside of Ohio, and then developed ectasia further in the left eye and had cross-linking in 2019. When he came to me, he had already been fit in many a soft, many a hybrid, and in scleral lenses, and had a decent refraction, you can see. And this is again after cross-linking. So he was 20/30, 20/40-ish, but it was just really bad quality. And he was pretty picky about his vision, and rightly so. He'd gone through a lot, and he's 43 years old. And so he just always said his lens acuity was shadowy, and he just was I could never get him happy. I was so happy. I was like, wow, you're seeing 20/20. And he's like, I don't like it. And again, he had read about CAIRS and CTAK and said, what do you think? And I said, what harm do we have? You look like a good candidate in general. Let's send you over. And he ended up having CTAK in both eyes. This is the patient I referenced. His fit is much easier. He's back into a basic lens. I mean, I was calling the lab and doing the most advanced designs around his ectasia appearance. And now it's like, okay, this is just a trial lens out of the set, put it on. The first one worked perfectly. And he is so happy with 20/20 clearer vision. I don't have his MR. He was actually seeing a friend of his that's also an optometrist, so I don't have his MR afterwards. But here, we can keep going. We can look at his map. So here he is in his pre-surgical right eye and left eye, probably a little, maybe on the edge of the zone, but when we send in all the maps, you'll see that it all met the nomograms for CorneaGen. So go ahead and go to the next slide. Here we go. Maybe a little blurry to you, but just kind of to point out, this is all before CTAK. His Ks 38 and 40 in the right eye, 46 and 47 in the left eye. And then next slide. This is after CTAK, so definitely less dramatic. If you can kind of remember the slide we just showed on his pre-CTAK, so a much smoother appearance. This doesn't fully get rid of the fact that he has ectasia, but definitely lessens the curvature here. And then next slide. Just zooming in here a little bit, definitely flatter. We're at 38 and 40 on Ks in the right eye, and 42 and 47 in the left eye. So I know those are a little bit blurry, but just kind of showing that everything kind of smoothed out here for the better. And then next slide. So here's the printouts that Dr. Wiley was talking about.
Yeah, you can see on this eye, where the green arrows show is right in the center of the visual axis. And you see that little yellow dot, that's actually the center of the treatment. So in this case, the treatment was decentered inferiorly. And if you remember where the cone was, it was a decentered inferior cone as well. So the segment, you can see now it's placed in that kind of inferior temporal quadrant, and that's sort of where that thin area was. And so you can more or less, it's bolstering with that sort of irregular thin area, pushing some of the irregularity either outside the visual axis or normalizing the more central cornea, visual axis cornea. And so this is kind of just a classic example of custom size, custom shaped, custom placement. That really is a map that we see and follow during surgery to make sure that this outcome is going to be suited for this patient's cornea. You can see in this case the inner diameter of the treatment zone is 5 millimeters and the outer diameter is 9 millimeters. The CTAK thickness in this eye was a 200 thickness. So it goes from, I think I've seen 200 up to 450. It may even go thicker than that, but that's the, it goes from 100 and so thickness all the way up to over 400 thickness, the length 160 degrees, and it can go almost 360. This is sort of a medium to smaller size length segment, so it can go upwards of 300, almost 360 degrees, depending on the cornea. So and there's there's a recommended and then alternate view of what the nomogram might suggest. So the surgeon does have some decision making along the way as sort of what would be the best recommendation for this patient. This is a typical op note. Thankfully, it's reimbursed, with at the surgery center. So we're op note from the surgery center, so that they have a professional or a facility fee, and there's a professional fee for the practice, and then there can be considered a cash pay refractive fee for some of the laser work that's done. So there's sort of 3 different modes of reimbursement depending on exactly where you're doing it and how you're doing it. But typically it's a facility fee, practice fee. And these are fees that are established fees that have been out for some time. It's not considered new. Let's say Intacs was kind of more of a research type experimental approval that was often hard to get pushed through the insurance. With this, it's an established corneal lamellar corneal transplant that all insurances more or less have been recognizing for decades. So relatively straightforward to implement from a reimbursement standpoint. Left eye, again, this one you can see that little yellow dot is inferior temporal compared to where the green arrows are pointing. So it's an inferior temporal placement. Again, custom size shape based on, and even where the incision is placed, you see the incision is placed at 30 degrees. So the incision is going to be placed on a particular axis that's going to allow for the placement of the CTAK segment to help kind of maximize the astigmatism correction and or normalizing of the irregular cornea. Yes, you can see this thickness. It's recommending a 450 micron thickness, but you can go, often, sometimes depending on what's going on, if it's previous LASIK or something else is going on, maybe I'll drop that thickness down, or maybe I'll bump it up. So they typically have a recommended, treatment at 450, but you can, make a surgeon adjustment, dropping it down to 400 or up to 500, depending on what the clinical scenario is. And
just have one for the left eye here.
Yeah, and this is the treatment. So you get an operative note for your femtosecond laser. And as far as the different lasers, you can use an Intralace, a Visumax, LensX, a Zemer. So almost, I think, now that I think about it, I think all the femtosecond laser platforms out there have the ability to create the channels. So chances are, if you're a cataract refractive surgeon, you have the tools in your practice to offer this.
Well, I will tell you, I saw this patient quite often, and now I don't. He's kind of a 1 to 2 time a year patient now, and his surgery was over a year ago. So it's been a great example. And this is just the post-op where, drawing where it's at, a little bit of haze that is cleared up in that left eye over time. And again, the patient did really, really well. It's great. I'm glad. Yeah, these LASIK patients, I feel like we have a responsibility. They undertook a refractive procedure that was, iatrogenic, and so it's not necessarily always a cause and effect. There could be other factors going on, but certainly in the patient's mind, they might perceive it as a cause and effect. And it's great for the field to take a patient that's been struggling. We really haven't had great treatments, and to normalize an irregular cornea, in particular in post-LASIK. Sometimes these are our happiest patients, and I've had some of the biggest wow effects for these exact scenarios. So our second case together is a friend of mine from high school, and had lost touch. And then his wife found a post, I think that Dr. Wiley and I had both done on Facebook. We've done some social media together. And she said, I think this lady fits, contact lenses for keratoconus. You should go see her. And he came in, and we're like, oh my gosh, I haven't seen you in so long. He is also very into the latest and greatest. He does a lot of research. He drives a Cybertruck. The day it came out, he was one of the first people to buy one. So he's really up on tech. And his keratoconus was progressing. He was diagnosed at 20. We saw him at age 43. Again, he'd been through the soft, the hybrid. I fit him in his first scleral lenses. He has very high myopia. Also, you can see irregular astigmatism, oblique axes. And his acuity in glasses in 23 and in scleral contact lenses was about 20/30. He was progressing. So in 24, he did undergo cross-linking at our offices. But in 24, he was just really still unstable with his RX, and he really was, his best corrected acuity was dropping even to 2200 in that left eye. And that's when he attended our keratoconus event and met Dr. Kirk and heard about CTAK and said, Katie, I'm always looking for the latest and greatest. This is, I feel, my next step. This is a true picture. It might be a little blurry on your screen, but this is an actual picture of his CTAK. So in 2025, just last year, he underwent the surgery in both eyes. And you can see in 26, just recently, we did another MR. And while he still has a good amount of prescription and astigmatism, he can be functional again. So he's 20/50 in both eyes, and he wears his glasses on the weekends. He takes a break, and he's so happy. And you guys, he's going to come back, and he wants ICL. So he will be an ICL patient for you in the near future, just to reduce some of that high prescription. but he is ready and waiting for that. And you'll probably be seeing him any day. And he's 20/20 in scleral lenses. Again, I don't have to fit him in anything too complex now. I'm very happy in just my standard type of scleral lens. Next slide. So just a few slides showing his pre-surgical. This is before cross-linking for him, actually. So this is pre-cross-linking tomography. And then next slide. Oh, it went a little fast. Let's wait and see where it lands. So this is just showing progression. He was 47 and 52 in Ks on the right eye, 49 and 52 on the left eye. And then the next slide. I love the comparison scan to show progression over time. It's probably, besides the Bellin, my favorite scan, so I can see changes over time. So if you go to the next slide. This shows his progression from 5.2 diopters of astigmatism to 5.7, and then 5.6 in the left eye to 6.5. So he's definitely progressing in a year. And so this is when he underwent cross-linking. At this point, we didn't have CTAK yet. Next slide. And then after cross-linking, we show comparison scans again. So go to the next slides. And here we can see he's now at 5.2 in the right eye, so he has less astigmatism even after the cross-linking, so things calm down a little bit, and 6.2 diopters in the left eye, so a little less than when he started with before cross-linking. And then the next slide. And then he went for CTAK. So here's kind of a more in-depth couple pages here on him. Any comments, Dr. Wiley? I know we kind of went through the scan.
No, this is great. If you want to just click to that refraction slide, I'm just curious if you pull that up again. I know it's back. I don't know if you can go straight to it. Dr. Kirk, do you want to talk about the your ICL that you did today? I don't know if you, I know we shared it together. Your thoughts?
Yeah, we actually did a ICL on a patient who had undergone CTAK. And so it was pretty cool to be able to see, we're going to be able to reduce this patient's refraction, maybe making them even more functional, which is such an incredible experience, and something where, this is not something we expected in patients who have keratoconus, that someday they may be able to be without glasses for some things, without contacts. And so just being able to give a little bit of that vision back is pretty awesome.
Yeah, it was cool to see. That patient had been a patient of ours for a long time. It was one of our early cross-linking patients. I had cross-linking, it locked his cornea in, and that was one of these patients. I said, you know what, we just have to lock your cornea in. I know it's not going to help your vision now, but it'll prevent changes, and technologies coming out all the time. There'll be something in your lifetime that can help your vision. I think we did cross-linking 10 years ago. And then, I think 3 or 4 diopters of astigmatism. We did the CTAK. It helped reduce that. His best corrected really wasn't great spectacle. He had to have contacts, but then once we put CTAK in, allowed him to increase his spectacle corrected vision. And once you have that good spectacle corrected vision, then they're a good candidate for ICL, because ICL sort of mimics that spectacle correction. And then we're able to offer today, we did his ICL. So it's been a journey over 10 years. He's had pretty much every corneal procedure or refractive procedure we could do. So, but he's going to be so happy to be able to be functional now without spectacles at all. So a great story. And, Katie, I think your friend could have that similar outcome. Same idea.
Yeah, I'm excited for him. So these were just 2 fun cases, one post-LASIK and one just a progressive cone. Bernie, do you have, in our last minute or so, do you have other questions for us?
Yeah, excellent case studies. And I know we are at time, but yeah, I just want a couple more questions here. You guys really answered a lot of these. The one question on is, can it be done after cross-linking? And obviously it can be. Any special, indication in a post-cross-link patient that you look at or look for when performing CTAK?
I'll be honest, I was nervous to do CTAK after cross-linking. in my Intacs day, it was almost a contraindication. I actually had at least one patient where I snapped the Intac on insertion. The cornea was so stiff and so tight, the tunnels are so tight that I couldn't insert. It was really hard to insert the Intac segment, and actually broke during insertion. It was causing so much pressure. And I thought to myself, there's no way I'm going to be able to put this, the CTAK in, which is obviously much more flexible than Intacs. But I think it has to do with an Intac channel is maybe a millimeter and a half or two, or I can't remember exactly the thickness, but it's such a tight tunnel. It's hard to put that segment in, and it's deeper too. So the Intacs are going at 400 microns, and maybe it's the depth of the angles or something. When they were cross-link, it was very challenging. Now with CTAK, if they've had cross-linking, really surgically, I can't tell the difference. It's just as easy in a post-cross-linked eye as it is, in a virgin eye. So no longer worried about that. I was initially, but now I look at those patients the same. And it's a great, a lot of these patients had cross-linking years ago, have been, patiently waiting for something that can increase their vision, and now's the time. So we've gone back and sort of mined a lot of our cross-linking charts and called them up, offered it, and said, hey, now we have that procedure you've been waiting for.
Question here on if it's covered by insurance, and I think Dr. Wiley, you covered that earlier. Again, anterior lamellar keratoplasty, CPT code 65710, and the tissue is reimbursed under the HCPCS code 2785. So that includes facility fee, surgeon fee, and the tissue fee, and that by and large has been working well for this procedure.
Yes.
Let's see, how about just in general, and this could be from the OD perspective and the MD perspective. The question was, how do you incorporate it into your practice? And maybe not so much the patient indications, but really just physically, how do you, what background do you need to do to incorporate the procedure from either a diagnosis point of view from the OD, and then from a surgical point of view for the ophthalmologist?
Yeah, I think it's just really having discussions with your patients. I think my keratoconus patients and my ectasia patients are the patients that I know the best. I'm closest with them. So just kind of figuring out what they're looking for. And, especially as I mentioned, both the cases are very tech forward. So if I wasn't mentioning it to them, they were going to figure it out and maybe think I wasn't, up to date on what the latest and greatest was for them. So I think the broader picture to all of our doctors there is make sure, even if you're not offering it, that you're very aware and you know where you can send for it. And then incorporating it into my practice, now it's just like, we have scleral lenses, we have CTAK, we have cross-linking, and then I look at that grid that Dr. Wiley had and like where they can fit into it. And then my referral to his office is not always just refer for CTAK, it's refer for options. And, if they've already had all the things done, then obviously it's for CTAK. But I do, want the surgeon to, have obviously that freedom with the patient. I trust him to make the best decision in his opinion for their case.
Dr. Wiley, as far as if you think back to your very first ones that you did,
Yeah.
Any pearls on how to get it organized and a procedure?
Yeah, I mean, relatively straightforward. I think from technically, it's very similar to cataract surgery. As far as setting expectations, very similar. That's corrected visual acuity worse in 20/40. So that patient flow, you need a diagnostic, let's say a Penicam, and then probably the biggest logistical scenario is where you have your femtosecond laser and where you can do the treatment. And a lot of times they're separated physically. And so right now where our laser center is a different surgery, different location than where the surgery center is. And initially we would, was worried about the timing. We do it, a day before always, and worried about that. But now, as long as you make that tunnel, you can do the tunnel, let's say on one of your laser days that, LASIK days that, for good or for bad refractive surgery, LASIK has been down a little bit, nationwide. So now that we have this opportunity, our laser days have a little bit more room on them, so we schedule our CTAK channel, the femtosecond channels on the days, on our LASIK days, schedule them, do the channels, and then they can come back, could be, a day later, a week later, a month later, to have the CTAK placed at the surgery center. So that, separating, and it kind of makes the surgery center the flow very easy. The patients already have the channels, they're already prepared, and then you just basically insert it, and it doesn't add a lot of time. I would say, your first case or two, you give yourself more time, but after that, it's probably going to be very similar to how long it would take you to do a cataract surgery. in that, let's say 10-minute range or so, something like that. So as far as it's not going to ruin your surgical day or your cataract day. It's very easy to put into the flow.
Excellent. Well, thank you all very much. Phenomenal job. Thank you very much for the presentations. And to everybody out there, of course, we give thanks to Doctors Suzanne Kirk, Katie Greiner, and Bill Wiley. For more information on CTAK, you can go to our website, go to CorneaGen.com and click on CTAK for lots of information there on how to get started. And thank you all for participating, and enjoy the rest of your evening. Good night.
Thank you.